and welcome to Rural Roots, a road less traveled, a podcast by North Country Healthcare.
We're your hosts. I'm Gavin Cook.
And I'm Ren Anderson, and we're so glad you're here. Gavin, we have Julie Bolton here with us today.
Yes, Julie is our system infection preventionist, RN. Julie, welcome. Thanks for joining us.
Thank you for having me.
Awesome. Well, we always like to start these podcasts off with a little get to know you. So if you could give us just a little bit about your background and what brought you to NCH.
All right. Nursing is actually my second career. I had worked 12 years as an environment health and safety manager for Ethan Allen. When they decided to ship jobs south or out of country, I took the opportunity and went and got a degree initially in environmental science, and then went on and got an associate's degree in nursing and started working as a nurse right away and realized that I should have done that in the first place. But I've also realized a valuable lesson that education is something that people can't take away from you, and it's valuable. So I embrace every second of it and use things I've learned in all of my education. So after graduation, I went on to work at Weeks Medical Center as a med-surg RN, worked there for 3 years, went over to home health, what is now North Country Home Health and Hospice. Worked there for a hot minute, decided that wasn't quite my fit. So I actually went up to Upper Connecticut Valley Hospital, where I worked in the emergency room for approximately 8 years.
Wow.
And when COVID hit, I decided it'd be a great time to take on infection control. Probably wasn't the best time, but a little bit of baptism by fire. I learned quite a bit. A little more about me and my background. I am a mother of 2 beautiful young ladies. They are both entering nursing. My oldest has a bachelor's degree in nursing and has already started working down in the ICU in Southern New Hampshire. And my youngest is graduating this year and pursuing her nursing career as well.
Wow.
As far as my education background, I have the associate's degree from White Mountains Community College. I went on to get a bachelor's degree from Southern New Hampshire University, and I am 1 or 2 classes shy of my master's degree from Southern New Hampshire.
Wow. Congrats.
So I think COVID certainly let the layman know a little bit more about infection prevention, but someone might still ask, what does infection control actually do, especially now that we're not in a pandemic? How would you answer that?
So there's a lot of things that are related to infection control in our everyday lives, starting with something as simple as washing our hands, washing our food. There are very specific standards that hospitals have to meet that require certain things to happen in the world of infection control. We need to be recording certain things, including who are the people that we're seeing, what are they coming into the hospital with, and what are we doing to help make them better, and also to help prevent it from spreading. So whether it's the flu or RSV or COVID, ideally, it doesn't really matter if it's a viral disease or viral issue. We need to head it off at the curve, keep our staff healthy, which keeps nursing and healthcare providers and environmental services at work so that we can keep our doors open and give our staff a healthy place to work, but also give our patients a place to come to get better. There's a lot to it. It starts with surveillance. It goes to education, and then it comes with preventative measures that we find as a result of the surveillance, with the goal being, quality healthcare and delivery that doesn't make people sicker than what they were when they came in initially.
That's great. And Julie, what's a day-to-day look like for you as the infection preventionist?
So we have 3 hospitals and a home health agency. So we have Androscoggin Valley, Weeks Medical, and Upper Connecticut Valley Hospital. Those hospitals have the capacity for anywhere from 16 to 25 patients at any given time. Depending on what we have for inpatients, they could be sick with anything from a congestive heart failure issue to having a baby, and so many other things in between. There's times when things are run, tests are run, such as cultures. People are required to have indwelling urinary catheters or PICC lines, or they have wounds that are infected when they come in to see us. We do a lot of measures and a lot of analysis to make sure that when they come in, that the right tests are run, that we take those tests into consideration with their treatment plan, that we ask the providers the right questions and help them have a quick progression of care. So on a Monday morning when I walk in, the first thing I do is I open my charts, I open my medical record system, and I start at the first hospital and I go through every single patient's chart that is an inpatient currently. We're looking to see, do they have an indwelling urinary catheter? Is it charted? Does it need to be there? Can we get it out? Are they on antibiotics? Are they on the right antibiotics based on the cultures and sensitivities that we are running? Did culture and sensitivity results get delayed for one reason or another? We ask very specific questions that are aimed at infection prevention measures, such as taking out those catheters early, such as not putting in a PICC line, which is a peripheral inserted central catheter, not putting in that catheter if it's not needed or if the person's infected. A common misconception about infection control is that we tell them what antibiotics to put the patients on. No, we assess, we make sure that they have all the tests appropriate, that we're asking the right questions. The providers work with infectious disease typically at the bigger tertiary care centers to make sure that we're using the right antibiotics based on the presenting signs and symptoms and the test measures. With all that said, so we check all the charts, we make changes appropriately based on what our nursing protocols allow us to do, and then we notify back to the providers if additional measures are needed, if they need to put in orders, or if they need to question, does this patient really need this today? Or we also help to escalate if a patient looks like they're going south, to help notify the providers if they miss them in the mix of 25 other patients, to make sure that they're escalating them and getting them to the care that they need as quick as possible. So chart checks is a big thing. We have to report to the Center for Disease Control, CDC, on a daily basis what our COVID, flu, and RSV numbers are in facility, and that's broken down from birth to infinite age. So 95, 100, it doesn't matter. Everybody in between, it's broken down in stages, and what they have for a viral illness. That started last November, and we chose to report on it daily because we find it's less to get caught and missed in the long run. That's done for all of the hospitals. We typically we do chart rounds where everybody tosses ideas back and forth and ensures plan of care is on par with acceptable treatment standards. So plan of care changes based on what the patient's needs are. That typically takes about an hour and a half for 3 hospitals, so a half an hour for each, but those are typically done via Zoom, which is amazing, by the way. Zoom or Teams. That platform has allowed us to work remotely or be in one location and move to the other in the event that we need to. Other things that we do, we follow up on any reports of issues something that could have gone wrong that needs to be improved. We are really striving towards high reliability organization and just culture changes in our delivery of care. And I very much so am proud to say that I am active in every aspect of that. If somebody comes to me and says this happened, we break it down, figure out where the failures were so that we can prevent it from happening again. And then take it and move it to the other 2 facilities. Or if it's something that's pertinent to home health, move it over to home health. Or if we could do something better and involve home health, pull them in. It's kind of become a really amazing team. So other cool things that we do fit testing. We fit test 630 people a year at home at North Country Healthcare for all of the healthcare agencies and deliveries.
And what is a fit test, Julie?
So when we're giving care to a person that could potentially be contagious, our staff could potentially catch it. So say if they have tuberculosis or if they have COVID even, that's something that droplets or respiratory, we could end up catching it if we don't have some level of protection. American National Standards Institute and OSHA and NIOSH, which is the National Institute of Occupational and Safety and Health, have very clear guidelines. They say, based on a risk assessment, if this is happening, you need to put a mask on your staff, or you need to make sure that they can wear it and be healthy in it and not cause them harm. And if you can't, then you need to put measures into place, such as a powered air purifying respirator, also known as a PAPR. In order for us to deliver care to that patient that is potentially contagious, we have to protect our staff as well. We learned that lesson the hard way a lot of times when COVID happened. If a patient walked in and we didn't have an N95 or a PAPR on, we ended up catching it. And then we would end up with no staff to care for the patients, or we'd end up with sick staff having to care for the patients. And there's nothing worse than wearing an N95 when you're sick yourself, having had COVID and having to wear an N95 and take care of other healthy people, but we had no other options because we didn't have the staff to care for them. So we basically follow OSHA standards, Occupational Safety and Health Administration standards, to put these masks on, have them safely wear them, have them dispose of them properly so they're not exposing people to other stuff. It does take about 7 to 15 minutes per each person. Multiply that by 600 and some change. That's quite a bit of fit testing. And we do it differently now. Previously, we would try to get them all to come to the certain locations to do it. We were finding it wasn't effective. Using the lean process, we actually started measuring it and realized that was really not effective. Our percentage for compliance was low. So we adjusted, we shifted, we put our stuff in a tote and we went directly to their workplace. And our penetration is better. We're seeing staff actually respond better. Initially, they were a little resistant. Now they're like, oh, this is amazing. I've got a busy day. I've got 6 patients to take care of, and I can do this and know that you respect my needs and my health, but you also respect that I have people to take care of. Yeah. So we also do flu shots. We do the same concept. We go direct to the staff. We do, I want to say, probably about 85% of our staff gets flu shots. People can get them elsewhere, but we can also deliver them as well. We also try to do preventative health measures as far as help keep people healthy at work. And encourage them to do things that are healthy as far as taking care of their mind, body, and soul. We do have a pretty decent holistic care program that we're working with employee health to help launch. Employee health and infection control do work a lot together, very closely tied together. Initially, my position did involve employee health and infection control. They did break them apart just for clearer lines of communication and clearer responsibility. As with anywhere in healthcare, we're trying to do more with less. And by blurring those lines a little bit, it made it difficult to keep it clear and to stay on target. By separating the roles and responsibilities, I feel it's more successful, and we're actually getting better penetration across the system. So
that's great. And I do want to just touch on something you mentioned earlier when we were learning about your background. So you obviously work in the ED, or the emergency room, emergency department. Can you talk about how your work with infection prevention also carries into the emergency department?
So that makes me think about back last December when everyone's like, oh, COVID's not a thing anymore, it's fine. I started looking at the people that were walking in the door, and I started saying to myself, we got problems here. We've got COVID, we've got flu, and we've got RSV all happening at the same time. By being in the emergency room, I'm seeing it happen in real time. I see what the staff is faced with. I see the shifting in the signs and the symptoms, so that people would look at someone and say, that's not COVID, and then know immediately once we test that, yeah, that was COVID, and things change. It's a moving target. We understand that it's something we have to take what comes at us in real time and shift almost immediately for the needs of our patients and also the needs of our staff. And I would say, it's very easy to get caught up in just writing policies and just looking at the numbers and just running the reports off of our board measures that we have. It's different when you're right there next to the person that's taking care of the initial patient walking in the door. If you're willing to, put on a pair of scrubs, throw your hair in a ponytail, and be right there next to them, it's much easier to feel what they're feeling and not necessarily have it be us against them. We're a team. We're in this together, and we want to protect you because without you, this doesn't happen. Our staff is important, and really working in infection control and the emergency room has allowed me the autonomy to establish relationships that I didn't have previously, and also to see what's different by each location and to see what we need to do for changes to help them be successful in their delivery of care.
Wow, what a powerful intersection to see how your work in the emergency department just immediately caught on that infection control and you were able to just shift. And I'm sure that relationship building makes such a difference. And we've talked, a reoccurring theme in our guests lately has been kind of we're all part of it. We're all a piece of it, and needing to rely on our subject matter experts like you to not only keep our patients healthy, but our staff healthy. It's just really insightful to talk to you and hear about all of those clinical aspects that you're working through every day. We heard a little bit about what it's like to wear both hats. That clinical hat and then that system level hat. Where do you find your inspiration to just keep going, especially when those might be at odds, or are they just never at odds?
Oh, they can be at odds. There's a few times where I have been in the emergency room and had a person come in and one of our staff members come in and have them test positive for COVID. Okay, you need to go home. You can't be here. We have the staff. You really shouldn't be here. Well, I don't want to go home. Okay, so right now I'm the nurse that just tested you, and I have a very difficult, I can't cross that line. You have the choice to yes or no make that decision. So we use the nursing measures. We use the things that we were taught right from day one in nursing school. Educate the patient. This is the risk. This is how this is how you're feeling. This is what you could potentially do to your patients as a nurse. And once you educate people, they tend to make the right decisions for the right reasons. There's a lot of conflicting demands on a nurse, and you're going to find, and actually not just a nurse, healthcare delivery. There's conflicted demands in basic human nature. Some people need to make sure that they get their 40 hours every week because they have expenses at home that require them to do so. It's understanding that they're people. They have needs, and we have to meet those needs in order for them to deliver care. It can be very conflicting at times. And I'm probably one of the biggest, not advocates, but I'm the biggest. I don't take that into consideration myself either. I'm a workaholic. I'm a single mom with kids in college. And I understand that, but sometimes you need to take care of yourself as well and advocate for your coworkers, your peers, and hopefully they do the right thing for the right reasons. It is difficult, though.
Yeah. I mean, you bring up a really human side of healthcare that I don't know that we talk about outside of massive need, and that is that all of our healthcare workers are really human. And Gavin, I'm going to put you on the spot a little bit and ask, when clinicians are faced, or anyone is faced with supporting their employee to get home to take care of themselves, and their employees are worried about paying their bills or worried about getting their own care, is there anything that North Country Healthcare does to help support those employees in those tough decisions?
Yeah, we have multiple different facets of directions we can go for that, but I always suggest when this topic comes up, our benefits specialist, Olivia Harris. She's the best point of contact. Whenever something comes up that's employee related, we welcome them with open arms, no matter the issue. We always say there's no issue that's too big for HR to assist with. Whether we have the answer or we can point you in that right direction, we welcome everyone through our door. Our doors are always open, whether that's through Teams or physically having the door open. We welcome that. But I would also like to ask the question to Julie of, from a human side again. Ren and I are not clinical folks. We're not in that world every day. So my personal this is kind of a personal question. What do you tell patients that don't understand what kind of care they may need, or what's best for them? How do you break that down to the lowest level of understanding, really, for those folks that just don't know the jargon, don't know the terminology?
So there comes a point in time when we have to pull out all the stops for patients. We have resources, amazing resources that now as a team NCH has been able to establish that we didn't have previously. It starts in the emergency room the second that patient walks in the door. We're assessing them, understanding what their demands are and also what their level of education and understanding are. And also like their level of wellness. Are they somebody who has, comorbidities that are that they're neglecting and not managing? Educating them, and if the education doesn't work, you go to the next level. You get case management involved. And case management can start in the emergency room, follow them all the way through care, and then refer them on to the next stage. If we need to get messages through our medical records system over to their primary care to get them in quicker, if we need to pull a few strings and get them appointments at a more urgent basis, we can do that. If we need to get, I actually did this last night on my overnight shift. I did a referral to home health for a safety evaluation in the home for somebody who was having continual falls. They don't need to be admitted. It's pulling the resources that we have and tailoring the care based on what the patient's level of understanding, level of wellness, and needs are. We're doing needs assessments almost the second they walk in to the second they leave. And then communicating behind the scenes to their providers. And if there's things that could have been done better and we see them as an incident, we're picking up on it, putting them into the systems for tracking so that we can do better next time and maybe change the system slightly to make it better and prevent the things from slipping through the cracks.
That's great. And what is one small thing that everyone can do that would make a big difference in either infection prevention or just overall community health?
Wash your hands. I'm sorry. No, I'm serious. Something as simple as washing your hands, that makes all the difference. You go back to, I've read multiple books by Florence that were authored by Florence Nightingale, and they start with cleanliness. They start with just the simple of bright light, fresh air. Get outside, stretch your legs, get some exercise, but wash your hands. So
great tip.
It's as simple as that. No, that's great. And I know we've touched on a lot of topics today, and it's opened my mind, that's for sure. But I'd love to know if you have any additional, anything you'd like to, as we say, plug to the community or to our staff, anything that's top of mind for you right now.
I would say that the biggest thing on my mind is the fact that we are a team, and there are so many members of this team, and every single person on this team matters. Environmental services, keeping these rooms and these spaces clean, listening to them at 5 o'clock this morning as they're shampooing the carpets down the central alley at Upper Connecticut Valley, knowing, talking with the managers, trying to come up with a better training plan to help penetrate their staff and to help them have a better understanding on how they're a part of the team and how they matter and how they're important and how when they come to work every day and they do their thing, it's noticed and it's needed, and we respect what they do. Food services, we need to feed these people, the patients, the staff, everybody. Our providers are, they're really the pillar that we all kind of cling to help us get our patients what they need. Our nursing staff, we're there when the providers aren't. We're there for the 23 hours and 55 minutes. We take a few minutes to go to the bathroom on occasion. Sorry, we're human too. Our lab staff, everybody in between, the human resources, our philanthropy staff, everybody. We are a team, and it takes a team. And it's easy to forget, and it's easy to get wrapped up in our area of care, and to lose sight of the fact that if it wasn't for Gavin recruiting everybody, that we wouldn't have any new nurses, and we would have more than the number of openings that we have, and that we'd be burning out our nursing staff. It takes a team, very much so.
Absolutely. Well, as we wrap up, I know Gavin always likes to know what inspires people. So I'll let him ask you that. But I also just want to know, what are you most excited about that's happening at North Country Healthcare right now?
I would like to say the HRO, the High Reliability Organization, how that's taking form and how that's coming together. Initially, I had a really cool idea, and Ren and I kind of muckled onto it and turned it into an escape room activity for 120 people. Though I wouldn't recommend that on a regular basis, because that takes a lot and that's a heavy haul. We are now working on the plan and developing SMART goals that are measurable, achievable, realistic. Developing those goals to help roll out the High Reliability Organization, using ways that are fun and ways that are understandable for everybody in all aspects of delivery of healthcare. So that your environmental services people have something that's pertinent to them, and then you also have, nursing have something that's pertinent to them, something that sticks, in that it's not just the flavor of the week. We want it to be something that's sustainable, and it will improve the delivery of healthcare and our quality of job, and our own fulfillment in what we do.
Yeah. Yeah, I think that that's a very exciting culture shift, and certainly it pairs so nicely with the One Team, One Mission initiative. And I hope Bernie's listening to hear how excited and passionate you are about HRO. We had him on and talking about the lean principles and how it all ties together. But I think it really comes down to continuous improvement from every position, and just that commitment that if you see something, say something, fix something. And it is really exciting to be part of that. So thanks for bringing that to light, Julie. Absolutely. Gavin, you want to wrap us up?
Yeah, I will hit it with my famous question here, which is, Julie, what makes you tick every day? What makes you get out of bed and keep coming back and serving our people and our communities?
Oh, that's a difficult question. I would like to think that it's my stubborn drive to want to do better than I did the day before, to improve on things that I see that are problematic, that could potentially lead to issues for patients, that could lengthen their care, that could contaminate our facilities, that so on and so forth. Just my sheer drive to want to do better than I did the day before.
Great answer.
That's some lean thinking. Amazing. Well, thank you so much, Julie. I know I've learned a lot. Gavin, I'm sure you feel the same way. And to our listeners, wash your hands.
Yes, thank you so much, Julie.
Gavin, how dirty do your hands feel right now? You ready to go wash them?
Yes, absolutely. No, it was such an insightful conversation. I honestly meant it when I said it's a personal question. Every time, I'm at the doctor's, I work in healthcare, and there's terms that even I don't know what they mean. So I love that there's that human side of being able to break things down and understand that even though she's in it every day and in the mud, not everybody is.
Yeah.
I loved that aspect.
Yeah, that health literacy
Yeah.
thing, that
Right.
enigma came up a lot during our community health improvement plan sessions, and how do we get better about it? And I also love that Julie said, "Hey, I'm not perfect at the human side of things yet," and she like showed us that growth edge, which I don't think we always see that vulnerability of leaders in our organization. So it was really nice to have her on.
Right. And before we look ahead to our next guest, I do just want to point out that we've had a few guests that I truly love the explanation of their growth and where they started and where they are now. It's truly incredible. Especially we had Daryl come on and he said he started in EVS, and he's our chief information officer now. And Julie started in EVS and now she's our infection preventionist. I think it's incredible. The growth we've heard from a lot of these stories. It's great.
Yeah, and it's a good plug for any
Right.
guests who are starting their journey that want to come on and be part of the podcast, because you're important parts of the puzzle, and we need to hear your stories, and you're the subject matter experts, and you're learning and seeing those things. So, just reach out.
Absolutely. Well, Ren, I will let you jump right into who's up next.
Yeah. So we're very excited that our next guest is going to be Evelyn Robinalt Jones. She is our clinical director of behavioral health and substance abuse services. And she was actually recommended to us to join the podcast. Lisa Rompre, who works very closely with our substance use disorder patients and programs, suggested that I reach out because she would be such a dynamic guest. So I don't know Evelyn very well, but I work with her on the ethics committee, and every interaction I have had with her, like most of our guests, she's just the bee's knees. So really excited to talk about her leadership in behavioral health and the heart that she brings and what the future of behavioral health at North Country Healthcare looks like as of this moment. So,
That's great. Well, looking
yeah.
forward to it. And I think what's important to note is that while we do all work together and we're all one piece to that puzzle that everyone keeps mentioning, you and I don't know everything about all of our guests. So I do think it's nice. There's some mystery to each guest,
Yeah.
and especially with Evelyn, I'm excited for that episode. So
Yeah, I mean, Gavin, you and I don't know everything about each
yeah,
other.
right, right,
So we probably should do an interview with just each other at some point.
right, right. Ugh.
All right. Well, until then, I'm Ren.
And I'm Gavin, and this is Rural Roots, a road less traveled.